This week on the BackTable podcast.
We have a sixth sense about where that invisible barrier that if you go beyond, you're going to get a complication. There's a sense of where that border is. And the specialists, the IRs that I know, like to go right up to that border and sometimes climb up that border without actually crossing it and just right there and push it as much as possible. But knowing just how much to push and when to stop and when to back off is incredibly important. I think that has to do with experience. It has to do with anatomy. It has to do with knowledgeology of what you're doing. It has to do with the materials that you're working with. It has to do with complication avoidance and knowing what's going on.
Hello, everyone, and welcome to the BackTable podcast, your home for all things IR and otherwise minimally invasive.
Before we dive into our topic today, just want to say a quick word from our sponsor, RADPAD. RADPAD radiation protection products, developed by physicians for physicians and clinically proven to protect during cine and digital subtraction angiography. Don't bet your health on anything less. Trust RADPAD protection for all your interventions. See radpad.com for more information and contact info@radpad.com to learn more about radiation safety CME credits for you and your team.
This is your host, Jacob Fleming. We're back with part 3 in this series on osteoporosis and treatment of vertebral compression fractures with Dr. Beall. So before we talk technical details, I'd just like you to give our audience a sense of magnitude of, how many levels of vertebral augmentation are you treating in a year?
So we do, year over year, we do between 600 and 700 patients a year. So we do a lot and have done a lot. And look, if I could do twice or 3 times as many, I would do that. Mm-hmm. I mean, this is one of the best things that we do. It's the best thing for people. It's durable, it's sustainable, it's life-saving, life-prolonging. There are very few things we do that have this degree of impact on people. And I love it. So we've gotten really good at it. We have all the tools to be able to do it. We do vertebroplasty, we do balloon kyphoplasty, we do implant augmentation with the SpineJack. One of the things that I'm really looking at is bringing vertebral body stent into the mix. I like the stent because you can pair it with a screw and do at the incident level of fracture, do multi-column treatment. It's called screw-assisted internal fixation. That term is coined by Alessandro Sinfoni, our colleague out of Switzerland. And this is the ability to treat severe fractures and join all 3 columns and treat somebody at the incident level. So, one of the things I want to listen, I want people to know what I'm about ready to say, because if you measure how much a vertebral fracture moves after you take an intact fracture and the end plates move hardly at all, you break it in a mechanical cadaveric model and you span it with it moves like this. So an intact vertebrae here, a fractured vertebrae, the end plates move like this. A lot of movement, right? You span that with pedicle screws and rods, it goes down to this. Barely any change at all. You do a kyphoplasty, end plates go way down. You do screw-assisted internal fixation, even farther, a greater amount of decrease. And then if you take this and you span it with additional screws and rods, it doesn't change it hardly at all. Spanning screws and rods don't do a lot to decrease the motion that's caused by a fracture. They just don't, it doesn't work that well. So you need some anterior column support. If we have the ability to do anterior column support, take the incident level of fracture, treat that, back it up, and because if you have a severe fracture in front, and I'm using the 3-column description by Denis, middle column is between the posterior portion of the vertebral body through the middle of the posterior elements. That's the middle column. The posterior portion of the vertebral body, if you do a great kyphoplasty and you take a severe and unstable fracture and you just do balloon kyphoplasty, the portion of that vertebral body at risk, greater stresses, is the middle column. So if you bridge the anterior column to the posterior column, that takes care of it. So it turns out you can do something that reduces the fracture, a stent or a jack in the front, put screws and back it up to all the way to the posterior column, and then you don't have to span it. You don't have to do spanning pedicle screws and rods. This is an incident fracture. You can take a severe or traumatic fracture, provided you don't have any instability beyond that incident level. You treat the fracture, you back it up with screws, and you will have locked that down and stabilized it as much as anybody at that incident level through 2 small incisions, about 8 millimeters, as much as can be done, including spanning that whole construct with screws and rods, screw-assisted internal fixation. So this is coming out hopefully very soon. This is being done in a few small centers, usually using a vertebral body stent in a cadaver lab, which was done primarily by a guy named Guillaume de Turte in France. We put pedicle jacks in. So the spine jack in front, joined to a pedicle screw in back, maximum stabilization. This is done through small little poke holes. This is something that used to be a 3-column surgery. You go in and go in through the front, go put pedicle screws and rods in the back. Complication rates very high. I mean, this is a very invasive thing. We've gone from that to fixing people with far less time, far less complications, morbidities, and blood loss and everything else, and providing a really stable construct. So this is exciting things that you're going to be hearing and seeing about here very shortly in the future.
Yeah, the screw-assisted internal fixation concept, I think, is one of the most exciting things in interventional spine right now. We'll also try to get a link to that paper by Dr. Sanfoni. It's got some great biomechanical data in there. And
Yes.
I agree, it's very exciting, and especially the vertebral body stents. I think for many of our listeners, this probably elicits some head scratching. These are not really stents that resemble the vascular kind we use in IR. These are more kind of like balloons with a border in a sense. That's kind of how I would describe them. And it seems like there's some definitely a lot of work being done with them in Europe and Asia, and in the US, we're a little bit behind with that, but it sounds like you're saying we can expect to see the advent of that on our shores, hopefully before long.
Oh yeah, let me give you a couple more things. So for the listeners that really want something new, here's a couple of new things that my guess is you've not heard of before. So number one, shaped balloons. So tell me why we put a balloon to press up a flat surface that is the end plate with a round balloon. It doesn't make much sense, right? So I'll submit to you that I think a flat surface is better pushed by a flat surface than a round surface. Just simple geometry, simple physics. And so the shaped balloons that come in to be able to push up against a flat surface with another flat surface, these are coming down the pike. Balloon within balloon technology. And we have multiple balloons that I've seen that you can reduce the fracture in multiple different areas, but multiple balloons to be able to press different areas of the vertebral body has to be separated on a catheter or anything like that to be able to reach different areas. What would be nice would be to have balloon within balloon technology to be able to do it within the same balloon. That's something that's directional, capable, and the ability to do different shapes and different things within the vertebral body. So that's coming to you soon. The other thing is different alloy. So the stent material that the VBS that's done by J&J DePuy is cobalt chrome. So, cobalt chrome is the same thing a lot of hip and knee replacements are made out of. It's a time-tested alloy, but it's not great in terms of tensile strength. Titanium alloy, same thing. It's been around for a long time. I just looked at a new alloy that's molybdenum and rhenium. It's called MORE, and this stuff is twice as strong, half as the size, because it's the strength, increased strength, and overall resistance will allow you to get by with using less metal in terms of heft. So it's non-reactive to tissue. It's stronger. It's lighter. It's much greater resistance for hoop strength. It's much more, at least if you have enough strength to move it, moldable, formable. So this stuff, in terms of the new alloy to be able to do great things, it's very strong and very light, may turn the next page on what we're able to do inside the vertebral body. So this is these two things combined with good film material, I think is going to be a very very much essential. And so one of the new cements I've been using recently is Vertifix Hb, and it starts off at 350 Pascal seconds. Most cements harden like this and get more viscous like this. This goes to mix it 350 Pascal seconds solidly. It has 18 minutes of working time. That's been a real advancement for me to be able to have something that's similar to the European cement cohesion that we don't have here that was developed for the SpineJack. This really works well with that. It works well with pretty much anything. So that's on the market now, but the two things, the shape balloon and the new, more alloy, that hopefully will be coming soon.
That's really exciting. One thing about the Vertifix, seen it, some of your work with that, it has these cool barium indicator beads. So that's, I think, a huge advantage. You know, one of the real boogeymen that we're always fighting in vertebral augmentation is cement extravasation, and especially pulmonary emboli. You and I are both well aware of the case report that was shown in NEJM earlier this year, pretty devastating cement pulmonary embolus. And I would basically chalk that up to, you know, whenever something like that comes up, it's basically becomes an argument for we shouldn't be doing vertebral augmentation. But that is a failure of treatment. And there's no reason to have pulmonary emboli like that. And so as our armamentarium has expanded, we have more tools that make it safer, more possible to do complex vertebral augmentation. That cement is definitely one thing that I think is really exciting, because you can really see the movement of the cement. You can tell if you're kind of getting close to the venous plexus. And the other stuff you're describing too, I think it's just expanding what can be treated minimally invasive versus with spanning pedicle screws and rods that don't actually help. Personally, I'm an optimist when it comes to this, but I think that in the next 10 years or so, these kind of fairly invasive spine surgeries for trauma will hopefully become more uncommon, and we move toward, vertebral body stenting, safe technique, and using some of the, just directional balloons and indicator cement. I think these are all things we should be embracing to advancing the technique.
Yeah, definitely. And I'll add a little bit about some of the complications with this. So, cement extravasation is well known. And I saw a case that had a cardiac embolus, and it was earlier in the year. It was a woman in her 30s, and they treated her with open heart surgery for a section of the cardiac embolus. I mean, what world are these people living in? I mean, so I got a call about a month ago from one of our colleagues, a little bit panicked about an Ivc extravasation. So it was a little glob of cement that came out in the Ivc, and she was worried about that. I said, well, just go in and basket it out. Just take it out. Just go in with a basket or a snare, some type of foreign body retrieval system, and take it out. So one of the things people don't understand is that cardiac little spike of cement that goes up in the heart that people were so panicked about. Ironically, it is the easiest thing in the world to remove through the femoral vein, right? I mean, it's not hard at all. So one of the things about cement that people sometimes have a hard time grasping is it's great for resistance, for compression and distraction. You could take a little chalk piece of cement, chalk shape, and you could take it, you could set it down on the table, and you could bang on the top of it, and you cannot break it. You can bang as hard as you want, but you take it like this, tink, break it. There's almost zero resistance to shear force. So if you see something like this, go in and with a snare and take it out of the femoral vein, and do not, under any circumstances, open a 30-something-year-old woman's heart because you're trying to take a piece of cement out of the right atrium that could have been easily retrieved percutaneously. So that's one of the things. That's a huge misnomer. I think that's to publish that in as without complete knowledge of, number one, how that happens, and number two, how you treat it, that's irresponsible for the medical journal. That should not be happening. how you treat it is the second thing. How it happens is either inattention or lack of knowledge about what you're looking at, neither of which are appropriate. So either number one, you don't recognize when extravasation is happening, or number two, you see it, but you don't understand what it is, or you're not paying attention to what it is. So none of this should ever be the case, and people can get pulmonary emboli. One of the things I want people to understand is that the incidence of pulmonary emboli, including small emboli, in the Venman's paper was 26%. So it's more, so small pulmonary emboli with augmentation may be more common than the incidence of blue eyes in the United States. So these are really common phenomena, and anything that happens in 1 out of 4 patients is probably normal and expected. It's just the volume of emboli. You don't want big emboli, and you don't want a lot of it because you can hurt people with it. But small emboli is kind of a normal part of it. I mean, it doesn't cause any problems. Small emboli have been around and present for a long time. It's just people don't recognize it unless you actually look for it, preferably with the CT, that you can actually see small little bits of radiopacities in the pulmonary arteries.
So I love what you described about the intravascular foreign body retrieval. Obviously, as an interventional radiologist, we do tons of IVC filter removals. So it's something that's definitely within the wheelhouse. And another reason why I think that interventional radiologists should be very involved in vertebral fracture treatment, because, you hear this all the time. And it's not to knock on any surgeons, but every once in a while you hear a surgeon saying, oh, IR shouldn't be doing XYZ because you can't manage the complications. And I would submit that what you just described is a place where we really can and are the best to manage the complication. And B, this is a little tangential, but I know you'll agree with me on this, is that a very significant portion of our work as interventional radiologists is managing other people's complications and doing it as minimally invasive as possible. Avoid, do we really need to do a sternotomy? And so, preaching to the choir here, but give your friendly interventional radiologist a call. If you got some IVC cement, that's something that is potentially amenable to, just a fairly simple retrieval procedure.
Anytime, that's a good point, Jacob. Anytime somebody says, well, only fill in the specialty blank, should be doing another blank procedure, you could be pretty sure that none of that's true, right? Yeah. Or none of that's valid. So, we do manage complications routinely of other procedures, and that's exactly what that is taking care of your own complications. And I don't expect everybody to take care of their complications, and we're certainly happy to help other specialties with theirs. Sure. No problem, right? We do complication treatments all the time, and we're happy to do that. I just don't want to be on the other side of that inaccurate statement, somebody telling our specialty what we should be doing and shouldn't be doing based on their opinion. Right. So, but pretty much as soon as people say that, you can bet that that's not the case.
Right. And so, as much as managing complications, we're interventional radiology really about complication avoidance and early recognition.
Yes.
And so I think that's really crucial when it comes to the problem of cement extravasation. And so can you just describe for our listeners kind of a situation, you're putting in cement and your spidey sense goes off, and what does that?
One of the things about IR is that I've noticed, because I work primarily with other specialties now, I don't work really with other interventional radiologists, is we have a sixth sense about where that invisible barrier that if you go beyond, you're going to get a complication. There's a sense of where that border is. And the specialists, the IRs that I know, like to go right up to that border and sometimes climb up that border without actually crossing it, and just right there and push it as much as possible. But knowing just how much to push and when to stop and when to back off is incredibly important. I think that has to do with experience. It has to do with anatomy. It has to do with knowledge of what you're doing. It has to do with the materials that you're working with. It has to do with complication avoidance and knowing what's going on. And I wrote a recent book chapter on complications of vertebral augmentation. And there's a lot of different types of complications. And before I talk about any other complication of this, I want to make the point that there was a 2019 paper by Liu that categorized complications from vertebral augmentation. Interesting part about this paper is that he also categorized complications of not doing vertebral augmentation. So as much as we talk about complications, all of this has to be done under the overarching knowledge that complications from not doing vertebral augmentation, somebody with a painful vertebral fracture that's a candidate for augmentation, is 9 times higher than complications doing the vertebral augmentation. 9 times. Yeah. So this is 15.52% compared to just a very small percentage of patients that had complications with vertebral augmentation. So whenever you're filling in a vertebral body and you see extravasation, the ability to recognize that extrav pattern is incredibly important. If it looks like the bone that you're filling, the reticulated appearance of the medullary or cancellous bone, and it's going back and it's not flattening out once it gets to the spinal canal, that's in the pedicle. If it goes globular under the pedicle, posterolaterally, that's posterolateral extravasation. That's no man's land. You won't hurt somebody like this. If it starts to go back, or let me go back one, if you have a vascular fill, that's easy to recognize. That's vascular. Duh. Paraspinal veins. If it goes back and right in the middle of the vertebral body and it starts to flatten out, that's the basivertebral plexus. And if it starts to make a lenticular shape, it looks like this, lenticular shape, stop. So if you keep going, you're going to squirt it out into the canal, and that's where you're running into trouble. Mm-hmm. The reason it goes and flattens out initially and then starts to make a lenticular biconvex shape, that's the anterior epidural ligaments. You have lateral ligaments there. You have a midline anterior epidural ligament called the ligament of Trollard, and God put the anterior epidural ligaments there so you could do vertebral augmentation and know when to stop. So that tells you when you see that flat area of extravasation, that's more dorsal, that's coming along that basivertebral plexus, and it starts to get a bilobed, a biconvex shape, a lenticular shape. That's when you stop and you let it harden in the anterior epidural space between the lateral anterior epidural ligaments. And if you look at this on CT, you'll see, and I have numerous examples. I can find one now within 2 minutes. It's confined on the lateral components, and it has a little cleft in the middle, like a little cleft in the chin. And that is the ligament of Trollard. Mm-hmm. That's why that little cleft is there, because of the anterior epidural ligaments. And so if you know the anatomy of extravasation and you understand how this happens and what to look for, sometimes, we extravasate, my fellow's panicking, right? It comes back and has the same pattern as bone, or it comes posterolaterally under the pedicle. I'm like, don't worry about that. And we go back and we CT almost everybody afterwards, checking our civil engineering of the spine. And he's like, well, how'd you know where that was? I said, because that's what it looks like, right? It's the immediate recognition of it. And if you are able to kind of catalog this, you understand the level of importance, because extravasation in some degree is normal. Well, it is normal. I mean, I extravasate almost every single case I do, but I've not ever knowingly had a nerve root or other injury at all based on that extravasation, knock wood, at all, that I've known about. Never. Because typically we're able to recognize where that goes. There's papers that catalog extravasation rates up to 73%. And it depends on whether you look for it under fluoro, by X-ray, by CT, but you can have extravasation rates that are incredibly high. And I'm sure my extravasation rate is over 50%. But it's not about extravasating. It's about filling the vertebral body end plate between the pedicle, accomplishing the goal. Mm-hmm. Because people that say, oh, I just poured a couple of cc's of cement in there and patients do great, is not true. It's not correct. It's not. And we should stop saying that, because there's whole, Roeder's paper, the Swiss registry. One of the things that you can do, the single modifiable thing that you can do to get better outcomes, is inject more cement. And as Alexis Kleckis says, our colleague in Greece, between the end plates, end plate to end plate, between the pedicles, that's how you fill it. And to fill all of the clefts, that's necessary, because if you don't fill the cleft, this has also been documented. That's a single thing, that filling that cleft, that you can be most assured that will decrease the patient's pain.
Absolutely. And it's, being in the middle of my diagnostic residency right now, you read tons of spine CTs, and we see some, work from all over, from outside facilities and wherever else, and see this not infrequently with, looks like they may be injected 2 cc's of cement. And it kind of makes you wonder what was even the benefit of that procedure other than a billable CPT. And so I am really happy to see a lot of recognition of the importance of filling the cleft. I see this a lot, posts on Twitter. Just in the last maybe year or two, interventional radiologists who are treating a lot of VCFs are getting very meticulous about their technique. And personally, I would credit a lot of that to your influence and some of the other people working in this area, just really making us come down hard on the technique. How can we push it further? And then what you're talking about extravasation and recognizing the patterns, it sounds so important, because when you notice that, what do you do next? It sounds like you're saying you give some time for it to cure and, harden, so that you're not worsening the extravasation. But then you don't abort the procedure there. You continue with the goal.
No, you just look, the best thing about cement is it hardens faster in the body than it does in the back table. So we let it harden. I mean, look, we have time. Relax. We have time, and it hardens. And if you go somewhere you don't like it to go, stop. And you can reposition the needle. You can reaccess the vertebral body. Then just stop and let it harden. And then when it comes along the basivertebral plexus and it comes up to there, I kind of like that, because I know that if I just wait a few minutes and let it plug that exit point into the canal, then after that I can just fire away and inject it pretty rapid fire, with good assurance that the basivertebral plexus, the most common area that you can get egress of the cement that can hurt the patient, is already closed door.
Yeah, that's a great way of looking at it. And so extravasation, I think it's a very important topic, and something that we have to be continuously aware of during the procedure, but not something that should dissuade the operators from accomplishing the goal they came in to fulfill in the first place.
Extravasation is normal. I mean, it happens the majority of the time. So just learn what is good extravasation versus bad extravasation. Learn what causes symptoms and what doesn't. Learn how to manage it. Learn how to accomplish the goal, because somebody that injects 2 cc's of cement in an L1 or L3 vertebral body, that's just not enough. That's whenever somebody doesn't get pain relief, they call it a failure of kyphoplasty.
No, it's a failure of technique.
It's not a failure of kyphoplasty. It's a failure of this, right? Not knowing that you need to put more in to accomplish the goal, to fill that cleft, to get rid of the vacuum phenomenon that's going on in the vertebral body, to have the ability to make an intra-body strut that can bear weight over time. That's what you're doing. You're not trying to glue the fracture together. Yeah, and the patient can absolutely have pain relief, but that's not what you're trying to do. You're trying to correct a pathologic vertebrae so they can bear weight on that thing for however much longer they have to live. That's what you're trying to do.
Excellent. And so while we're talking about fills, I was wondering if you could just briefly talk about how do you decide amongst your toolkit, vertebroplasty versus kyphoplasty versus implant augmentation? What are the things you consider?
I love implant augmentation. I mean, if you can reduce it, you probably should. And there's nothing that reduces it as good as the SpineJack in the U.S. We don't have VBS stent outside. It's all OUS. But, if you can reduce it, might as well should. We like the jack. I do a lot less balloon kyphoplasty than I did at one point in time because of the reduction component. I really want a balloon that I can press up against the end plate flat to flat surface and really get great movement on that. I think I'm excited about that new prospect. I still do, moderate amount of vertebroplasty. I mean, if you have a fracture that's non-compressed and you just add some stabilization component to that vertebral body, why not? So, but, frankly, Jacob, as you know, I mean, we love augmentation. Neil Chonard, one of my friends out in, who's worked for Proliance Surgery, he's an ortho spine guy. He ranks, if memory serves, 21 different things that they do to the spine. They have a ranking in terms of outcome and patient satisfaction. And they do everything, soup to all the way from spinal deformity surgery all the way to simple injections. The single greatest thing, the highest ranked procedure in terms of patient satisfaction and outcomes is vertebral augmentation. That's why we like it. And because it works, and the immediacy of how fast it works is also very gratifying. But, I'm not about immediacy. I'm about durability, and I want patients to get better and stay better. And, I worked my whole career to have a my mother practice, meaning that if my mother came in, I would be happy and satisfied with the way that she was treated, not only episodically, but durably as well. And so I think if we, now that much of IR is more of a surgical sub than it is part of radiology, I think we have to look at that. I think we have to look at a sustainability, as especially I think we have to look at comprehensive treatment. I think we have to look at making our mark as minimally invasive surgery or whatever we want to call this. I think we probably ought to have a new name, because, it's really not very descriptive of what we do.
Mm-hmm.
And I think we just have to start looking at life to make not only a viable existence as practitioners, but to advance that practice of minimally invasive fix-it shop type work that takes everything into consideration in treating the patient in a holistic manner. So we get not only disease process correction, we get the ability to repair, correct, fix somebody in a minimally invasive way, and whatever it takes to make that durable, to correct that problem. And as soon as we do that, I think that's what makes it sustainable.
That concludes part 3 with Dr. Beall. Stay tuned for the final part coming out soon.
Thank you so much for listening. If you haven't already, make sure to subscribe, rate the podcast 5 stars, and share with a friend. If you have any questions or comments, direct message us at @_BackTable on Instagram, Twitter, or LinkedIn. BackTable is produced and hosted by myself, Aaron Fritz, and co-hosts
Chris Beck,
Sabine Dond,
Michael Barraza,
Brian Hartley.
Our audio team lead is Kieran Gannon, with support from
Caleb Hodson,
and Ness Smith-Savadoff.
Design and digital marketing led by Brian Schmitz.
Article and transcript support by Taylor Robinson.
And Delaney Aguilar.
Social media and PR by Ann Dang.
And newsletter by Lauren Fang.
Intro and extra music is Ripperoo by Skeptic Moon. Find us on Spotify or at local live music venues in New Orleans, Louisiana.
Thanks again for listening, and see you next week.